Welcome to Getting Started and Latch Assessment Tools, the first webinar in our 4-part Breastfeeding Skills Session webinar series. I am Amy Gohl, the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing the 4-webinar series. A few pieces of information before we get to our speakers. The speakers and planners have no relevant conflicts of interest to disclose. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Within 1 hour after the webinar ends, you will receive an email with a link to the survey. You will need to indicate on the evaluation whether you would like to have nursing contact hours, CERPs, both, or neither. Certificates of completion will be sent via email next week. This program is being recorded and will be available on the Partnership's on-demand education page until September 2nd, 2022. Our first speaker for today is Teresa Mancuso. Teresa has been the Lactation Program Coordinator at Englewood Hospital and Medical Center since 2015. She has held multiple roles in perinatal and pediatric nursing, parent education, and lactation support in her career as a nurse and international board-certified lactation consultant. Today, Teresa will be kicking off our webinar as she looks at getting started.
Thank you, Amy. I'm glad to be here with you today. So I think our job as nurses and lactation consultants is to educate our patients. We need to give them current, evidence-based information, and then they need to decide what is right for them and their new family. Breastfeeding and the provision of breast milk are the gold standard and the normative way to feed a baby. We know that babies are healthier when they are breastfed, and that the best outcomes are for babies that are exclusively breastfed, which means that they're only receiving breast milk from birth. What we say to parents really matters. But as we know, it's not just the information that we're giving, it's the way that we communicate that makes the difference. So when you're first meeting your patients in labor and delivery, aside from all the other information you're going to be sharing with them, you need to have a discussion about their plans to feed their baby. But you want to watch the way that you ask the question. You don't want to make it like you're simply completing your charting and ask, are you breastfeeding or formula feeding? Because when you ask it like that, it kind of equates the two. You want to have more of a conversation with your patient. You need to sort of see what she's thinking, ask open-ended questions, and be non-judgmental. You also are trying to assess her knowledge and what she knows about breastfeeding. One good way to start a conversation is, what have you heard about breastfeeding? This gives you a great opportunity to sit back and be passive and simply listen to your patient and what she tells you. This will help you to be able to, based on what she says, to clarify or correct misconceptions and to tailor your information to the questions she has and the experiences she brings to the situation. One example is when I teach prenatal classes and I'm asking a patient what her plans are in terms of feeding her baby. Sometimes a mother will say, or soon-to-be mother will say, I'm really nervous, I'm not going to be making enough milk. And when she says something like that, that really is a great way for me to share with her that that is a fear that many women have as they're having a baby, and be able to share information with her that meets her needs, which is to share with her the small newborn stomach size and the presence of colostrum and the adequacy of colostrum, and even the principles of how breastfeeding works with supply and demand. I think before the birth of the baby is a great time to set up expectations with your patient in terms of what's going to happen based on the delivery and based at the particular hospital you work at. So at our hospital at Englewood Health, when we have a healthy term baby, the baby gets dried off, the baby's put skin to skin with the mother and covered with nice warmed blankets, and the nurse can routinely do assessments and vital signs and APGARs with the baby in a skin-to-skin position. And then at some point, when the baby starts to become more interested in feeding and shows hunger cues, the baby will start to, will latch and start to breastfeed. In addition to talking to soon-to-be new parents about the initial birth and the initial attempts at breastfeeding after skin to skin, it's also a really wonderful time to talk to them about what the expectation is in terms of supporting exclusive breastfeeding for a healthy term baby. In terms of, you can talk to them about what their plans are in terms of feeding their baby. But I would clarify that you're getting an idea of what their plans are for when they are in the hospital. Sometimes when you ask a patient what their plan is to feed their baby, they'll answer both or combo feed, because they're thinking a little bit more long-term than we are. They're thinking, well, I have to go back to work at some point, or I will want my husband to give a bottle. So when we're talking about feeding plans, we're talking about what are their feeding plans while they are in the hospital. All right. In terms of coming up with your own strategy, you really have to sort of work on a script of what feels comfortable to you and what verbiage sort of works for you in terms of having a conversation in terms of how you approach how the baby will be feeding in the hospital. So this will be based on just your own comfort level and sort of works what makes sense for you. And it will be based on the patient that you have. Sometimes you could have this discussion with the patient before she delivers. Sometimes you will need to wait until the baby is born because that's a better time for the parents to focus. You may be the mother-baby nurse and seeing this mother over on the mother-baby unit and letting her know information in terms of what to expect in terms of the feeding plans and what will be going on with the baby for the day. So you have to sort of come up with what makes sense in terms of feeling comfortable. As we said, it's not just sharing information, it's a conversation. When I, as a lactation consultant, when I'm meeting a patient on the mother-baby unit and talking to her about the process of breastfeeding and how it sort of works, the way that my little script is, I sort of say something like, well, what we think makes a lot of sense is that while you're in the hospital is to give the baby lots of opportunities to practice breastfeeding. And that way the baby can have, lots of opportunities, lots of times to practice with these phenomenal nurses around if you get into any problems. And that way it's going to make it so much easier to go home with your baby. So for me, I find that kind of is the way that I introduce the idea of exclusive breastfeeding for a healthy newborn. But it's very much based on the patient that you have and their situation. So if it is a multip that tells me that she's going home and she has a 2-year-old at home, and now she's thinking about what she's going to be doing in terms of feeding this baby, then I sort of switch gears and say, well, then what would be really a great idea is for you to exclusively breastfeed this little baby while you are in the hospital. Because as you know, going home to a 2-year-old with a newborn, this is as quiet as the world gets while you are here. So it'd be really wonderful if the baby can figure out how to breastfeed while you're here. It will just make your transition to going home so much easier. In situations where the question is asked about their feeding plans and a patient says that they're going to combination feed, I'll support that and I'll say that would be great. But what we would think would make sense is while you're here in the hospital, figure out breastfeeding. Lots of opportunities, lots of practice. So by the time you get home and you are, drowning in milk and the baby's nursing well, then, a bottle doesn't really cause us as much of a concern. I'll say formula is not bad, but it's a lot faster and a lot easier sometimes for certain babies. So we would love for a baby to really kind of figure out how to breastfeed while they're in the hospital. So as I said, I think a conversational tone, open-ended questions, sharing information, being non-judgmental, and having the patient ultimately decide what is the right thing for her and her family. I think that also it's important what we say to patients, but it's also important what we should not say to patients. I don't think it's any of you guys, but occasionally you'll hear from a patient, oh, I was told I have a flat nipple, or I was told I have an inverted nipple, or I was told that I have a very difficult breast, or the baby's not interested, or the baby doesn't seem to like the breast. You know, comments like that can first of all be inaccurate, and second of all, it doesn't really serve a purpose. It really just takes away the mother's confidence and sets her up for some increased anxiety. So, you know, a lot of women are very concerned about the appearance of their breasts. You know, you hear from women a lot, you know, I don't know if this is going to work. My nipples are too big or too little. My go-to line is that, you know, the baby has never seen another nipple in their lifetime. They're not sitting in the nursery comparing notes. So your baby will figure out whatever your nipple or breast looks like. And that usually makes them smile. But I think the point is made. So here's a picture, gorgeous little picture of our little baby here, skin to skin. So what is skin to skin? Many of us have, you know, walked into a room, sorry about that, have walked into a room and been told that the baby is skin to skin. And meanwhile, the baby is all wrapped up in the mother's arms in a couple of blankets, or my very favorite is the baby is in the bassinet, and they are thinking that the baby might be able to breastfeed from there. So skin to skin is a baby dressed only in a diaper and a dry hat, upright between the mother's breasts, with a covered with a warmed blanket, with their head turned to the side. And this is a nice little picture of skin to skin, and you can see the little baby there with the little tongue out, starting to get interested in feeding. So in terms of skin to skin, you know, why does it help? Well, babies are mammals, and like all mammals, they're born with reflexes that allow them to survive, and part of survival is being able to feed. And in terms of the these reflexes, how do we stimulate these reflexes? Skin to skin, okay? Once again, you'll come up with your own verbiage when you talk to your patients. My verbiage is that skin to skin is like preheating the oven. You wouldn't just put your turkey into a cold oven and start from there. It doesn't sort of make sense, and that's sort of the same concept. So putting a baby skin to skin, when a baby wakes up and is looking and is starting to get interested in feeding, you know, babies just don't wake up and eat. Putting a baby skin to skin gets them more interested, gets them to sort of connect a little bit more with their mothers, and usually will get a baby to become more interested in feeding. So I use my, you know, preheating the oven line. Other one is rebooting the computer, especially in this technological world. You know, my husband is a computer person. Whenever I ever called him about a computer problem, he always just said, simply turn off the computer and put it on again and reboot the computer, and that usually fixed things. And the same thing with skin to skin. So when a baby is sleepy, when a baby is mucousy, when a baby is not too interested, skin to skin in many situations will put the baby into a situation where they will get more interested in feeding. So you really can use it to your advantage. So initially after birth, the goal with a healthy mother and baby is to initiate skin to skin immediately after the birth and continue it until after their first feeding attempts. The New Jersey Department of Health regulations supporting breastfeeding says the routine skin-to-skin contact with the mother or primary caregiver as the preferred source of body warmth during the critical first hour of life should be the practice unless such contact is not medically possible or declined by the mother. Okay, so we're talking a healthy baby should go skin to skin after the delivery. We know some of the benefits of skin to skin and breastfeeding within the first hour are associated with higher rates of exclusive breastfeeding and a longer duration of breastfeeding. Earlier establishment of effective suckling and feeding behaviors, a improved neonatal temperature. Babies stay warmer when they are skin to skin with their mothers. Okay, and respiratory regulation, improved blood sugar stability. A lot of times we're worried about baby sugars. The act of a baby being skin to skin in itself will bring up the baby's blood sugar. Enhanced maternal-infant interaction and bonding, and higher levels of maternal oxytocin release. And the bottom line of it is babies love skin to skin and mothers love skin to skin. Let's also just remember that skin to skin is not just about breastfeeding. In many cases, when a baby is put skin to skin, the baby will get interested and start to breastfeed. But for a mother who chooses to formula feed, she should still be encouraged to do skin to skin after delivery because it is facilitating the baby's transition to extrauterine life. It's not simply to get the baby breastfeeding. Okay, so now that we have been talking a little bit about skin to skin, this is what skin to skin, as I said, our cute little picture. Our next picture is kind of, bad skin to skin and good skin to skin. So the picture on the left was actually taken by a dad after the delivery of his baby. He was just taking photos, and then after the fact, it was sort of realized. Thankfully, the staff that were there realized that in this situation that the baby's airway was obstructed and the baby was quickly repositioned and any tragedy was averted. So this is showing, how not to do skin to skin. The picture on the right is showing a baby in a more appropriate skin to skin position. In terms of skin to skin, here's another little sweet baby with their mother skin to skin. Skin to skin, the baby should, mom should be in a semi-reclining position, optimally at a 45-degree angle. She should be sitting up. Ensure that the baby's face and nose are turned to the side and visible to the mom and her partner. And that's important. Sometimes moms will want to cover the baby with a blanket. Moms start asking for breastfeeding shawls and wraps, or being worried about their visitors' comfort level or for privacy. But the baby's face should be visible to the mother and to her partner. Ensure that the angle of maternal recline facilitates eye-to-eye contact with the infant. The baby should be able to see the mother should be able to see the baby. If the mom is tired, ensure someone has the responsibility of constant observation of the baby's color. And that's important. After delivery, women can be tired. Put the baby skin to skin. And if you are moving away from the side of the bed, then I always say to whoever's there, the partner, whatever, you sit here then, just in case, mom gets a little tired, and just sit there and keep an eye on the baby and make sure that you can always see the baby's face and their color. And then my favorite is if we can possibly discourage the use of texting or mobile phones immediately after delivery, that would be a beautiful thing. I don't know how realistic, but that would be a beautiful thing. Okay. All right. In terms of the next slide, this is just an example of one of the many handouts that are available online that can just be posted in patient rooms to reinforce the principle of the importance of skin to skin. This is one of my favorites. This one is It's My Birthday, Give Me a Hug, which is available from the Massachusetts Breastfeeding Coalition. And aside from a sweet little picture, it really does a very lovely explanation about skin to skin. and the importance of breastfeeding initially after delivery. Our next picture is, this is a handout that we actually have at Englewood Health, and this is in the LDR rooms and the mother-baby unit, and it is, you know, just really sort of is another reinforcement and visual reminder of the importance of skin to skin. So these are some of my ideas in terms of some strategies on getting breastfeeding started and off to a good start initially. And thank you for all you guys do in terms of supporting your patients on their breastfeeding journey. I think we have time for a couple of questions.
Thank you, Teresa. We do have a few questions.
Okay.
The first one is, as a labor and delivery nurse, I really support my patients breastfeeding, but lots of days we are too busy or understaffed to have babies skin to skin. Isn't this unrealistic in most hospitals?
Well, that's a great question. In the reality, skin to skin actually makes your job easier and not more difficult. A baby is going to need to feed after they're born. Putting a baby skin to skin really does most of the work in terms of getting the baby interested, and the baby will usually, in most situations, end up feeding after that. When a baby is skin to skin, in a way, it takes a little bit of the pressure off. After the baby's placed skin to skin, then as a nurse in your L&D room, that's when you have now available time. That's when you can chart, that's when you can dispose of medications, that's when you can clean up anything you need to, get paperwork done. But it really is a very good use of your time. So it doesn't really make your life more difficult. It actually makes things work easier for you. Same as on the mother-baby unit. When we see babies on the mother-baby unit, our usual practice is that if a baby's having trouble feeding and a lactation consultant's going to see them, we don't go into the room until the baby has been skin to skin for about a half an hour, because we know that that is going to do most of our work of getting a baby interested in feeding, and it will be much easier to help her with positioning or answering her questions or helping her problem solve after the baby is much more interested in feeding.
Well, anything that helps, that's great. Here's the second question. When I tell my patients that we are going to be skin to skin and then attempt to breastfeed after delivery, some of the responses I get are, I'm too tired, I'll breastfeed later, or I want my family to come in and see the baby. How should I handle this?
Yeah, those are the questions that and the comments that you hear a lot with new parents. Yes, they are excited their baby is here, but they are they want to share it with other people, and they are tired. What I try to just state is that that first hour after delivery is just such a critical time. The baby is going through so many changes and transitioning, and it really it is just such a, the literature shows us that babies are the most interested in feeding right after they're born. So you want to take advantage of that time. They call it the golden hour for a reason. And there's a fabulous film that's on the bibliography from Global Health Media that shows just different babies in skin to skin, and how it really allows you to just be passive, put the baby skin to skin, and let the baby latch on their own without us really doing very much. So I would sort of just let them know that it really is just in their best interest to really take advantage of that time. And the fact that they're tired, my line is, you're going to be tired for years. After a baby's born, they are looking to feed, and so you really want to take advantage of that wakeful time to get in a good feeding before the baby does get a little bit more tired. And it's sort of just the way that they feed in the beginning sort of imprints upon them as this is the way that they're supposed to feed, and it just will make the next couple of days go much easier.
And our last question, what about if the baby goes to the NICU? How will that affect skin to skin and breastfeeding?
Well, in terms of there's always, depending on what's going on, babies can be born with medical issues, and mothers can have complicated times as well. If a baby is not medically stable and is not able to do skin to skin right away, that's fine. Once they're in the NICU and they're stable and mom and baby are medically ready to do this, then they will have plenty of time to do skin to skin. They should never be disappointed that they've lost the opportunity. There will be plenty of time for skin to skin and breastfeeding as well.
That's great. Well, thank you so much. That's all we have time for today.
Great. Thank you, Amy.
Our next two speakers are Jeanette DePrimo and Joanne Wells. Jeanette began her career as an antepartum nurse and later spent several years in staff positions in labor and delivery, postpartum, and childbirth education. She has been practicing as a lactation consultant for 15 years, 13 of them at Hackensack University Medical Center. Joanne has been a lactation consultant also at Hackensack University Medical Center for the last 15 years. Prior to that, Joanne served as a staff nurse in the hospital's mother-baby unit, NICU, and newborn nurseries. Both speakers hold Bachelor's of Science degrees in nursing and are international board-certified lactation consultants. Today, we will hear them discuss Latch Assessment tools.
Hi, I'm Joanne, and this is Jeanette, and we're going to present positioning and latch. First, we're going to discuss a little bit about positioning and the latch assessment. Positioning is most important for mother and baby for the comfort during their feedings. The latch assessment tool is just one method that we'll use for assessing a baby's feeding. Maternal newborn nurses are challenged with and are accountable for their own standards by making accurate assessments and developing their appropriate interventions for care. The acronym LATCH means L standing for the latch of the baby on the breast. A is for audible swallow, which sometimes you don't hear in the first day or so until the milk volume increases. T is for the type of nipple or the breast with the mother, so we can assess that. And H stands for hold. And through that process, we can come up with a score that gives everyone an idea of how well the baby is doing during a feeding session. Hearing and looking at the baby during the latch is important, but two main hormones are so important during breastfeeding sessions. The receiving prolactin and oxytocin are the mothering hormones that are present at the time that the baby is delivered and the placenta is exposed. So the prolactin is for the production of milk, and oxytocin is for the release of milk while the baby is doing the sucking. And those two hormones are the most important at the time. So Jeanette is going to be actually going through the assessment of the breast and the inspection of the breast.
Once we introduce ourselves to our moms, we like to make them comfortable. We have a few pillows that we give them to support their backs. We have some extra pillows to assist with the support of the breastfeeding positions. One of the things we do is a breast assessment. So we do palpate, feeling for any lumps. We look for any scarring that may be visible on the breast. If we do see any scarring, we will ask the mom if she's had any kind of breast surgery, whether it's breast implants or breast augmentations or reductions. This helps us develop a plan of care for breastfeeding, because once we know she's had surgery, it may actually affect some of the ducts that will supply the milk to the baby. We also do a nipple assessment, so we're looking for an erect nipple, or sometimes we do see a flat nipple, or maybe it's just a little shorter, or sometimes even inverted. Again, this is so that we can establish a plan of care for our breastfeeding couplet. What we'll start with now, the first position is going to be cradle hold. And cradle hold is usually used for moms who have had other experiences with breastfeeding several children. They're totally comfortable in their hold. They kind of know what they're doing. They feel that cradle hold may be the best hold for them. So I'm going to demonstrate once we hand the baby over to mommy. You just want to make sure that the baby's head rests kind of on the crook of mom's arm. She's supporting the baby's back, pushing the back in, baby shoulder blades close to her breast. And she's also bringing the legs around the chest as well. With her free hand, she can support the breast underneath using the C hold. We always try to encourage the C hold on the breast because a lot of moms try to do what we say the scissor hold, but sometimes that can affect the latch and cause nipple pain because the baby's mouth isn't covering the entire breast and areola. So once we make sure that the baby's on mom, we try to tickle the baby's mouth. Mom will use her nipple to stimulate the baby to try to open his mouth. Many babies are sleepy, so we do try to motivate the baby before we hand him over to mom. Once the baby is close to mom, we use her nipples just to try to gently stimulate the baby's lips. When mom sees that the baby's mouth is open with a wide gape, that is when we usually ask mom to bring the baby in as close to her breast as possible, chin touching the breast, with mom always being able to see the baby's nose. How does that feel?
I think this is a lovely position. The baby actually wants to touch my breast. Is that okay?
Absolutely. Massaging the breast actually helps the milk flow, and it helps to stimulate the breastfeeding. It helps baby become a little more motivated when he feels all that milk being flowed into his little tummy.
The movement from the ear is, I see movement and I see the jaw opening. Is this what you're explaining?
So some of the signs that we know baby's feeding is active temple jaw movement. So you want to see the baby's temple and jaw moving. We're also looking for those fish lips. I'll demonstrate with the breast as well. So the fish lips should be at least a half inch past the nipple. Those fish lips, the temple jaw movement is what we're looking for to show that the baby is feeding. The mom may also feel some tugging or pulling. That's normal. Pain gives us an idea that the baby's either not positioned well or maybe didn't have a wide enough gape and is just maybe sucking on the nipple instead of the breast and the areola.
Okay.
Feels good?
Yes, this is nice.
Okay.
I also like the boppy pillow, or we can use regular pillows too if I can have that, right?
We can always use, you should always use enough pillows, and remember to put the pillows breast height. A lot of the moms tend to put the pillows too low, and so they tend to bend over instead of having the baby brought to mom so that mom can be a little more comfortable, and that also encourages baby to give us a deeper latch. The next position I'd like to show you is football hold. Football hold is used frequently by our C-section moms because it does prevent any pressure on the uterine incision. And with football hold, again, it's always tummy to tummy, so baby's tummy is facing mom. And with her free hand, she's also going to support the breast in a C hold. And we always encourage moms to support the baby's bottom. So baby should be well aligned to mom's chest, the ears, the shoulders, the body should be well aligned. If mom is skin to skin, and that's something we will always encourage skin to skin, or as I tell my moms, topless mommy, topless baby, because then they get it. They understand that they have to remove everything from their waist up. Once baby's skin to skin, it allows baby to keep warm and also allows him to get a deeper latch.
Gee, I had a C-section and it feels so much better. I don't have any pressure exerting on my belly. So that feels nice.
Wonderful. We're always looking for mom's comfort. We know that if a mom is comfortable, then she'll be more than likely able to breastfeed throughout the night as well.
Do I have to hold my breast all the time?
Not all the time. I always feel that initially holding the breast gives that breast a little bit of support so that baby can latch on a little easier. You can always use the free hand to massage your breast and to help with milk flow.
Oh, like this?
Exactly.
This helps milk come down?
Absolutely. The release of the milk will also motivate baby to suckle for a little longer.
This is such a wonderful experience.
Also, once baby is feeding and he starts to fill his little tummy up, he'll start to slow down on the feed. His body will look more relaxed. His hands will just fall to his side. That's how you know when baby's getting enough of his fill. And mommies may feel slightly tired or drowsy.
Always tired.
Very thirsty. So
Yes.
Make sure you have plenty to drink at your bedside. And of course, you can always drink and feed at the same time.
Yes, I can drink when I'm breastfeeding.
Absolutely. We want you to hydrate because hydration is always going to enhance your supply.
That's wonderful. And I do like this position.
Another position that I may show you is cross cradle hold. In cross cradle hold, again, you're going to bring baby all the way to the other side using the same arm you did with football. And this time your free arm will slide underneath your breast on this side. So if you're feeding on the right breast, it will be right hand supporting the right breast. Then you're bringing your baby, again, tummy to tummy, skin to skin, well aligned, supporting the baby's bottom.
You know, I'm noticing the nose is very close to my chest. Is that okay?
Well, just give him a little bit of room because you do want to always see the baby's airways. You always want to hear the baby breathing. So sometimes you just have to alter your position just a tad so that you're able to see the nose.
You know, the baby's head is getting very heavy. Is there anything else I can do?
Sure. We can use some extra blankets to place under the baby's head.
Oh, that's perfect.
For some extra support so that the mom won't get too tired. We're really looking for mom's comfort because we do know that if moms are comfortable, they will continue to breastfeed.
Oh, I see the jaw moving. I see the lips flanged. Is that what you told me before?
Absolutely. That's going to prevent you from having any nipple soreness. If the lips are too close or really just clenching on that nipple, it will cause nipple soreness. And breastfeeding shouldn't be painful. You may have tugging, you may have pulling, but it shouldn't be painful. If it is painful, sometimes all we have to do is tweak the position, or we may have to detach the baby by slipping one of your little fingers into his mouth, releasing, and then repositioning the baby.
Can I let go again of my breast in this position?
Sure, you can let go and bring your arm around to support his head.
All right, baby stayed latched on. That's good.
Good. We want to see the baby latch and we want to see him feeding. And there may be times when you may actually hear him swallowing. The first few days, colostrum is small amounts, but as the days increase, you're going to see and hear more swallows. So look or listen for the audible swallowing. How is that? May I teach you the laid back hold?
Sure. Is that another one I can do?
One more, yes.
Oh my
Let's
goodness.
remove this. Let me just hold the baby.
Right.
And with the laid back hold, we do ask moms to have a few pillows supported. And this position is great if a mom is really just tired of sitting up, or maybe her perineum hurts. And she's just had a long labor. She wants to breastfeed, but she's kind of not motivated to. So once we get moms comfortable, we can then, again, we can either do a cross cradle hold, where baby's, again, skin to skin with mom, tummy to tummy. Mom may either just support his head this way, or she can go into the full cross cradle hold.
And that's putting my hand
Putting
here.
your hands here and supporting the breast with
Supporting
this
my
side.
breast. This is very relaxing. My bottom does hurt today, you know. It's
Okay.
like the second day, so I'm really feeling sore. But resting back, I feel more comfortable.
Great.
And the baby is sucking nicely.
And any one position may be different for some other moms. So if this position is best for you, then you can use this position. Maybe later you can try the football hold. That's a different position that you may be comfortable with, or that maybe baby will decide he wants football hold. He doesn't want the laid back hold this time. So it's always good to know a few positions.
Yeah, that's exciting. I'm so excited, Jeanette. You've told me so much.
Thank you.
And it's really making it worth our while. So in summary, I guess what you're telling me is that after reviewing the anatomy of the baby and breast positioning and latching, I'm going to be a successful breastfeeder. And we can provide all the mothers with all the understanding and knowledge they need to take home with them so they can have a good experience with their baby. And we want them to go home breastfeeding. So thank you. It's wonderful that we've been able to spend a few minutes together. And I think the time and session's closed, so there may be time for questions.
I hope so.
Thank you, Joanne and Jeanette, for a very engaging presentation. Great job. And almost makes me want to have kids again. Not quite. So we do have a few questions. The first one is, what cues will the baby exhibit to let the mother know that the baby's hungry?
Well, first off, when you're with your baby all the time, rooming in the hospital or even at home, you're going to follow the cues of the baby, not so much the clock. So you're looking for the hands going to the mouth, the eyes fluttering, gentle body movements, and that's usually your signals that baby is getting ready for a feeding. If the baby is waking and crying and mommy just missed those little tactile cues, we have to comfort the baby and start maybe skin to skin and gently bring that baby centered, and then start again, trying to get the baby ready for a feeding. Sometimes the cues could be a wet diaper, could be a burp, a loud noise that they've heard somewhere, and then just assume that, gosh, it's probably 3 hours or so, or 2 hours, and looking at the clock, I think it's time for us to try to feed the baby. Number one, you can never overfeed a breastfed baby.
Good point. Okay, question number 2. If mom has a C-section, what position do you recommend as best for her to use while she's feeding the baby?
Well, again, we want to make sure that mom is comfortable, so we can automatically try the football holds because we do know that that takes the pressure off the incision. And with football holds, once again, we're just bringing the baby to the side, supporting the tush, his back, and allowing some of that pressure to come off the incision. If mom is not comfortable with this hold, we can always go back to cross cradle or maybe even the laid back hold. But most of our moms do prefer the football hold in the beginning.
Great. I think you talked about this a little bit, but we have this question as well, the final question. Is it normal for mom to experience pain when she's breastfeeding? And I think we talk about both nipple or breast pain and then maybe uterine discomfort.
So in the beginning, when we do initiate the breastfeeding, we really want that baby to have a wide gait because we do find that if the baby just opens or has a narrow gape, he then just starts to bite on the nipple. So we have to be patient and do a lot of stimulation on the baby's lips. And then once the baby opens his mouth wide, then we can bring him on. So painful breastfeeding is usually a sign that maybe we have to either correct the position or detach the baby and just start again. It is common for moms to have uterine contractions during pregnancy, during breastfeeding. We do encourage them to continue taking their pain medication as needed. A sign of uterine contractions is that's a good sign. It means the baby's actually stimulating the hormonal release and the uterus is going back into its own shape. So that is a good sign, but we all know that pain is not a good experience. So we do encourage moms to take their pain medication as needed.
Great. Thank you so much. That's all we have time for today. Thanks so much for our speakers today and to Monica Smith, who handled the technical back end of the program. Just a reminder that in about an hour, you'll receive an email with a link to the post-program evaluation. Certificate of completion will be sent out in the body of an email next week, and we'll be using the email you provide on the evaluation. Our breastfeeding webinar skills session series continues next Thursday, September 10th, with some of our regional lactation consultants presenting hand expression and alternative feeding methods. Links to information about other upcoming webinars and our on-demand educational opportunities may be found on the partnership's website on the professional education page. In addition to our webinars for professionals, the partnership has a variety of resources to support new mothers who are breastfeeding. Our Sisters Who Breastfeed program in Paterson and Jersey City is a collaboration with the Perinatal Health Equity Foundation. This support village is for Black women who are breastfeeding or plan to breastfeed and offers virtual support, connections, and resources. More information and our other resources can be found at partnershipmch.org. Thank you for joining today's program, and we hope you can be back with us next week.